Up to 40% of all patients with uncomplicated peptic ulcer disease don't have symptoms. Older people, in particular, are likely to be symptom-free. Pain is the most common symptom of peptic ulcer disease, and it's often felt in the upper abdomen. It's often described as gnawing, burning, or tenderness, and it might be relieved by food or antacids. Because ulcer pain can radiate to the back, the chest, and other parts of the abdomen, it's sometimes mistaken for other problems, including a heart attack. Pain that disrupts nighttime sleep often indicates a duodenal ulcer. Other possible symptoms include nausea, vomiting, and heartburn. Severe abdominal pain, loss of appetite, weight loss, black or bloody stools, and vomit that can include blood could indicate an ulcer complicated by bleeding or perforation. Anyone experiencing these symptoms should seek immediate medical care. Bleeding internally is the most common complication, occurring in up to 15% of patients with peptic ulcer disease. Ulcers caused by non-steroidal anti-inflammatory drugs are more likely to bleed than those caused by Helicobacter pylori infection. Perforation, where the ulcer breaches the wall of the duodenum or the stomach, causing damage to nearby tissue and organs, occurs more commonly in older patients, and it's a medical emergency requiring surgical intervention. Perforation occurs in 2 to 10% of peptic ulcers. When perforation directly affects an organ, it's called penetration. Obstructions that block the stomach emptying can result from inflammation, spasms, or scarring from recurrent ulcers. Symptoms of obstruction include repeated vomiting as well as sustained fullness and bloating after eating. Helicobacter pylori associated peptic ulcer disease increases by 3 to 6-fold the risk of developing stomach cancer later in life. The diagnosis of peptic ulcer disease begins with physical examination and thorough medical and family history. The exam and the history help to rule out disorders that can cause similar symptoms, including gastroesophageal reflux disease, heart attack, gallstones, irritable bowel syndrome, and cancer. Upper gastrointestinal endoscopy is necessary for a conclusive diagnosis of a peptic ulcer. An endoscopy allows the inspection of and the biopsy of the stomach and the duodenal lining, as well as a direct culture for Helicobacter pylori. A biopsy is necessary to distinguish peptic ulcer from ulcerative malignancy. Immediate endoscopy is recommended for patients with signs of gastrointestinal bleeding and/or urgent symptoms, including excessive vomiting, difficulty swallowing, and excessive weight loss. A complete blood count, a CBC, and a stool occult blood test are recommended for patients who are suspected of having a bleeding ulcer. All patients with suspected peptic ulcer disease should be tested for Helicobacter pylori. Techniques that can detect the Helicobacter pylori include blood tests to measure the Helicobacter pylori antibodies, a urea breath test, a stool antigen test. Additionally, follow-up testing 1 to 2 weeks after completion of treatment should be used to confirm the Helicobacter pylori has been successfully eradicated. The presence or the absence of a Helicobacter pylori infection is a critical determinant of the ulcer treatment. Beyond eradication of the Helicobacter pylori, symptom relief and promotion of ulcer healing are the main treatment objectives for uncomplicated peptic ulcers. Complications like an uncontrolled or recurrent bleeding, perforation, and obstruction may require surgery. The 2017 clinical guidelines from the American College of Gastroenterology for the treatment of Helicobacter pylori recommend as the first line of treatment either a combination of 3 antibiotics and a proton pump inhibitor. A medication like bismuth quadruple therapy. This uses bismuth preparation, 2 antibiotics, and a proton pump inhibitor. Multiple variations of treatment based on these or similar combinations of drugs can be considered. All recommended treatments are for 10 to 14 days. The eradication of Helicobacter pylori by antibiotics is the mainstay of treatment for peptic ulcers associated with Helicobacter pylori, and it results in 70 to 90% of a cure rate. The recommended first-line treatment can be a combination that includes clarithromycin. Clarithromycin resistance plays an important role in the variable estimates of the cure rate of the Helicobacter pylori and the peptic ulcer. There's a growing problem in the US and Canada. There's resistance to levaquin and other antibiotics. Proton pump inhibitors are drugs that block the secretion of stomach acid, allowing the ulcers to heal and often relieve the pain. Proton pump inhibitors also enhance the efficacy of antibiotics in the Helicobacter pylori eradication. Helicobacter pylori eradication regimes are generally brief, lasting from 10 to 14 days. However, when used long-term, the proton pump inhibitors are associated with a wide range of serious side effects, including kidney and cardiovascular disease. Bismuth-containing medications like Pepto-Bismol reduce the gastrointestinal acidity, and they improve the efficacy of standard antimicrobial treatment against the Helicobacter pylori. Bismuth rarely causes systemic side effects, but it can result in black and tarry stools. Salvage therapy is sometimes used where the initial therapy fails. This strategy uses different antibiotics than those previously failed, and the bismuth quadruple therapy or regimes containing levofloxacin are preferred as salvage regimes. In addition to antibiotic resistance, poor compliance is an obstacle to an effective treatment. Triple and quadruple therapy are complicated, expensive, and they cause side effects, mostly digestive, in about 30% of the patients. In most patients, drug therapy relieves the ulcer symptoms, but in some cases the symptoms persist despite the effective clearing of the Helicobacter pylori. Long-term management of dyspepsia with acid suppression or other treatment might be helpful in these cases. For patients with peptic ulcers who test negative for the Helicobacter pylori, non-steroidal anti-inflammatory drug use should be discontinued. Antacids and medications that reduce the acid secretion, like proton pump inhibitors, are then used in these cases. Antacids neutralize the stomach acid. Antacids that contain bismuth and a combination of aluminium hydroxide and magnesium hydroxide are available over the counters. These drugs usually cause only mild side effects like diarrhea or constipation. H2 receptor antagonists block the acid stimulation action of histamine in the stomach. Examples include cimetidine. They're available over the counter, but a prescription is required for higher doses. Serious side effects caused by the H2 receptor antagonists are rare, but they're more common in older patients. H2 receptor antagonists can reduce the B12 absorption, so B12 status should be monitored for the long-term users, and B12 supplementation should be initiated if a B12 deficiency is detected. Mucosal protective agents are used to help to protect the stomach lining against the damaging effects of the non-steroidal anti-inflammatory drugs in patients who have to continue to take them. Mucosal protective agents also inhibit stomach acid and pepsin production. They can cause other gastrointestinal side effects relatively frequently, and they're contraindicated in pregnant women because it can cause a miscarriage or birth defects. Maintenance therapy is recommended for patients who experience recurrent ulcers. Maintenance therapy generally involves the long-term use of antacids, H2 receptor antagonists, mucosal protectants, or other proton pump inhibitors. Although the proton pump inhibitors are usually considered the most effective maintenance treatment, the long-term proton pump inhibitor use is associated with an array of grave health consequences and an increased risk of death. Although proton pump inhibitor drugs are widely used, they're associated with a number of potentially serious outcomes. Moreover, many people who use the proton pump inhibitors for longer than directed can exacerbate the side effect risk. Over-the-counter proton pump inhibitors should not be used for more than 2 weeks, and prescription proton pump inhibitors should be used only as directed, never use more than 8 weeks. The long-term use of proton pump inhibitors, more than 4 to 8 weeks, can lead to physiological deficiencies of important micronutrients like calcium, magnesium, and B12. These deficiencies increase the risk of a host of conditions like musculoskeletal and neurological abnormalities, heart rhythm irregularities, and increased risk of cardiovascular disease and diabetes. Several other studies have found proton pump inhibitor use is associated with an increased risk of death from any cause. In one study that enrolled 491 patients with an average age of 80 years, the proton pump use was independently associated with a 51% increased risk of dying during a 1-year period. Those on the higher dose of the proton pump inhibitor therapy had an almost 2.6-fold increase of dying within 1 year. Proton pump inhibitor use has been associated with heart attacks in several studies, though a causal relationship between proton pump inhibitor use and heart attacks have not yet been established. One study of over 126,000 proton pump inhibitor users and an equal number of non-users found the proton pump inhibitor use was linked to a 58% increased risk of heart attack over a 4-month period. Proton pump inhibitor use has been associated with kidney damage and chronic kidney disease. One study in over 184,000 individuals found that those with kidney disease were twice as likely to have used a proton pump inhibitor. Proton pump inhibitor use appears to increase the risk of community-acquired pneumonia. It can increase the pneumonia risk by several mechanisms. The inhalation of the pathogens from the digestive tract that would normally be killed in the more acidic condition, and the change in the normal bacterial population of the airways due to the acidic reduction in the respiratory tract, and the proton pump inhibitor directly impairs the immune cell function. Clostridium difficile is a bacteria that can lead to potentially severe intestinal infections. Proton pump inhibitor users who also take antibiotics have a particular pronounced risk of a C. difficile infection. The FDA issued a warning to patients taking proton pump inhibitors that they should contact their health provider immediately if they develop diarrhea that doesn't improve. Several studies have correlated the long-term use of proton pump inhibitors with an increased risk of fractures, including fractures of the hip, the spine, and the wrist. The impairment of calcium absorption is one of the factors that can contribute to the increased fracture risk that's observed with the prolonged proton pump inhibitor use. Proton pump inhibitors alter the populations of microorganisms that inhabit the gastrointestinal tract. This can lead to small intestinal bacterial overgrowth, which can increase susceptibility to non-steroidal anti-inflammatory drug-induced injury to the small intestinal mucosa. Alterations in gut microbial composition are also implicated in the observed link between the proton pump inhibitor use and celiac disease. The more research is needed to firmly establish the influence the proton pump inhibitor use has on celiac risk. Gastric acid normally breaks down potentially immunogenic proteins that are found in food, but acid suppressive therapy can hinder the process, causing reactive particles to pass into the intestine and trigger an immune response. Studies have demonstrated an increased incidence of hypersensitivity reactions to both foods and drugs in proton pump inhibitor users. In hospitalized patients, those who are taking proton pump inhibitors were nearly 4 times more likely to develop drug hypersensitivity reactions. More rigorous prospective research is needed to establish the degree of causality in the relationship. People who use proton pump inhibitors for more than 8 weeks should consult with a qualified healthcare provider to discuss the risk and the benefit. In some cases, long-term risk might outweigh the potential benefits, and the therapy should be discontinued or adjusted. Each case is unique, and healthcare providers should take the patient's complete history into consideration. For more on peptic ulcers, continue on the series. And for information on herbs, supplements, and natural treatment plans, check out my website.